Thank you,
The floor belongs to you.
for your very kind introduction. Shukantada is a year senior to me, and I learned a lot from him in the college. Until now, we are learning from him. Respected chairpersons, good morning, everybody. You have had a lot of discussion on the clinical and the lab parameters till now, and something I'm going to discuss will be much lighter and thought-provoking, and maybe there is a competition at the end of the presentation. So we would request all of you to suggest names for PCOS that we can put forward in the PCOS Society International. So, can you recognize this fruit? So that's a kiwi. So kiwi is originally a Northern American fruit which was named Yang Pao. So Yang Tao from China was imported to New Zealand, and the farmers in the New Zealand started producing it, and they named it as Chinese gooseberry. When it was very popular in New Zealand, they thought they would export it to US, and to catch the market, they had a big meeting to find out what should be the name. Because at that point of time, Chinese and berry was very popular in America, and Chinese was not. So mixing up Chinese gooseberry and sending it for sale in America will not make any market. So at the end of the meeting, it was decided, put something that will make it known that it has come from New Zealand. So this bird of New Zealand, kiwi, they put the name as kiwi fruit, and all of you know how popular it has become in US and also in India. We know it by the name of kiwi. So name does matter. The name PCOS, that is being tagged with a disease where we are always looking at the ovaries, and in your clinical practice, you know how many times the woman come to us and says, I had PCOS, I have been treated by a gynecologist and I don't have it right now. Means she has got a OCP, which is suppressing hypothalamo-pituitary gonadotrophin axis. There was no maturation of the eggs, and there was no follicles, there was no cysts, and she thought that she is now treated completely of PCOS. Coming back to you after 5 years, again I have the same problem. So this problem should be understood by all of us and should be addressed like that. So if you try to remember that many of the medical diseases have been named earlier in the name of the discoverer, and later on, for example, Koch's disease later on changed to tuberculosis, because that's what the physicians understand better. The patients will also understand that. Like Hansen's disease later on changed to leprosy. Similar happened in the opposite direction as well. Like Mongoloid babies. Later on, when Downs explained the chromosomal association with it, then it was named as Down syndrome. So things went on like that. What happened with PCOS 300 years back, when first Valsineri in Italy found out during an operation such large bumpy pigeon-like eggs, he did not put any name to it because he was quite amazed to see such things. And again 100 years passed when Sheru, a pathologist, cut open the ovaries and found that the stroma is much thick and called it sclerosistic changes. Again, no name has been put to it until the smart guy Stein in 1935, almost 100 years back, found out 7 consecutive women who had amenorrhea, who were obese and infertile. He did a laparotomy and took out a part of the ovary, and some of them, when 5 of them started ovulating, 2 of them got pregnant. Then only the name Stein-Leventhal was coined to this disease. However, the evolution went on, and when we were studying in our college, we called it polycystic ovarian disease. We thought something to do with the ovaries, and we were taught like that. Later on in the 80s, polycystic ovarian syndrome, because it was thought it is no more a disease. It is also associated with some other problem in the body. And in 2000, we expect that we would change the name so that we understand it more. So these are the names already being proposed, and we think from India we should also propose some more names. Two names went from India. Khadilkar from Mumbai, from the Endocrine Society, and HAPODS, hyperandrogenism, persistent ovulatory dysfunction syndrome. Like that, another went from our side, that Behera, estrogenic ovulatory dysfunction. Syndrome O, because it's a syndrome, not known till now how many things will be associated with it. Syndrome Z. Two-state solution, Fauser came out with it, that is in the NIH in UK. Then functional female androgenism, somebody told it is associated with metabolic problems, so it is metabolic reproductive syndrome, so on and so forth. So we have not till now fixed up a name, and all of you have got a chance to put a name so that you become famous worldwide. Why I became interested in this subject is because of the girl over here. When I just postgraduated in 1988, this girl came to my clinic, and she was 18 years old with chronic anovulation. At that point of time, we had an ultrasound machine. We found out that there are cyst-like structures in the ovaries. Polycystic ovary was known to us at that point of time. But you can see she's quite beautiful, slim, no hirsutism. But when she brought her sister, after she got perfectly treated, you can find the sister was quite fat, obese, with a bit of a, hirsutism. And she had polycystic ovaries, but periods were, the longest period was less than 35 days. So not of a very much concern about that. But when her mother got a heart attack at the age of 45, then we started thinking, this is the lady who has got two children, two girls who have been without any assistance, were born. And suddenly she had developed, some cardiac problems, and then she passed into being diagnosed as a type 2 diabetes. What is the association? Association was not found at that point of time. I had this picture from Puri. She had sent me this picture, and now we could associate that these are all the part of a same syndrome. Her aunt, and she conceived, probably Ratna Chatterjee, did her IVF at SIR's Dr. B.N. Chakraborty Center. She conceived by IVF, not knowing properly why she was not conceiving at that point of time. A whole family full of PCOS problems. And these girls, cousin, she has got extreme hirsutism and was treated in a very famous Dr. Subrata Malaka's chamber due to her hirsutism. And when we looked into her lifestyle, we found out that she is quite obese. She was not menstruating properly. She was not concerned about that. She was taking homeopathic medicine, so on and so forth. And lastly, this lady, because by that time I was also in infertility treatment, and she conceived at my place with an IUI, she was also PCOS. So look at this family, and then gradually we were thinking about having genetic predisposition of this. And similar, at the same time, throughout the world, people have started thinking in that way. Professor Rajan from Kottayam, at that point in his book, had a chapter on PCOS where he graded into 3 grades. No cysts in the ovaries. Even then he was calling it PCOS. People started laughing. However, he was right at that point of time. So in 2003, when Rotterdam, probably Ratna was also with me over there, PCOS was at that point of time thought is ovarian dysfunction, which is not so. So the cardinal features you know very well: anovulation, oligovulation, and biochemical markers of hyperandrogenism. And third point was polycystic ovary changes in the detected in the ultrasound. However, 15 years later on, when we went to the same conference in the Barcelona, we found that along with 2003, there are some more things have been added. For example, USG findings was not mandatory at that point of time to diagnose it at PCOS. So please, the gynecologist, when somebody comes and says, I had PCOS, and you find in USG nothing, she got a lot of progestogens or OCPs, no ovulation, so no maturation of the eggs as well. So it is not at all mandatory nowadays to diagnose it as a case of PCOS. The diagnosed patient, first of all, not being treated for anything else, but should be treated with the lifestyle management and psychological support. They are very depressed at the end of the day. And they should be given, even if adolescent, 12 years old, they should get low-dose OCs. And metformin is the first line of treatment for the prevention and treatment of the metabolic problems. Along with it, something else have also been added to this. Letrozole has become the first line of ovulation-inducing drug. And if you give metformin and clomiphene together, that is also very good. And gonadotropins in the second line of management, so not in the first line. And one very good thing has come up for all the infertility specialists, that IVF should be considered if COS with gonadotropins fail. So for PCOS, you must consider IVF as one of the very, very important mode of treatment. Side by side, our colleagues of endocrinologists were coming up with an androgen excess and PCOS society, and they came up in 2006 giving more importance to the hyperandrogenism features. They were in some part, they were true, because not only it is going to give rise to all these changes, but later on to the metabolic problems. So now we have got two features in our hand. One is hyperandrogenism and one is ovarian problems. So keeping behind the ovarian problems, let's look at the hyperandrogenism problem. And now it is being named as PCOS, is a functional ovarian hyperandrogenism. You know how it happens due to excessive LH and escape from the desensitization and from the ovarian as well as from other extra-ovarian sources. There is increased intra-ovarian androgens, there is follicular arrest and more LH-FSH and more hyperandrogenism. However, now Professor B.N. Chakraborty came into the scene and he taught us that no, hyperandrogenism didn't come first. First came hyperinsulinemia, and the same word was told by the stalwarts throughout the world. And so now we looked at the hyperinsulinemia because that was not a realm of gynecologists. That was a metabolic problem. So we found a lot of insulin. We started measuring it, which we are not measuring now. It is so certain that all PCOS women will be having hyperinsulinemia in majority. So this hyperinsulinemia coming from the beta cell action, from insulin resistance at the peripheral level due to receptor and autoantibodies, as well as insulin clearance from the hepatic clearance being less. So we know it is giving rise to obesity, and obesity is giving rise to hyperinsulinemia, and these are ultimately is giving rise to hyperandrogenism. Now came the words about the receptors, receptor at the level of the ovaries, and insulin receptors, insulin-like growth factor receptors, and ultimately we found that we have to measure SHBG, which is being lowered in these cases. This is the end of a story, and now again a new story has started, emerging factors, metabolic syndrome and its consequences, of which now we are in communication with the health ministry so that they should come into the picture. Otherwise we cannot prevent so much epidemic of women after 40 having cardiac problems in India. So for that we are in relation with them. And last but not the least, we should look behind, not only after 40, but before the baby is born, before zero, fetal affection of PCOS mothers. A lot of things have come up. So not only metabolic, but look at this intrauterine, what is happening. At the 50 days of gestation, the hypothalamo-pituitary gonadotrophin apparatus in a human fetus is functional. And that point of time, if the mother is PCOS, has got hyperandrogenic state, then the maturational process of this endocrine organ is influenced by the programming. So the girl, child, the fetus is becoming programmed to become a PCOS when she is 50 days of gestation, not even 2 months. So this has become very important factor nowadays. We have to treat the mother. So you're doing IVF without treating the mother, without giving metformin, and she is conceiving, you are making another human being, bringing another human being on earth who will be having PCOS and all its metabolic consequences in later life. So you can go on seeing how many things have been published. Fetal androgen excess provides a developmental origin, and you know the genes that encodes this CYP17 and CYP11A. So these responsible genes are in the androgen biosynthetic pathway, So when it has been found, this is the trial study report that came up with CYP17, that in the second trimester of pregnancy, it is being programmed, so the key androgen biosynthetic enzyme that is being programmed in that way, this is to P450C17, and then came the pediatricians into the field. They said when we are getting these IUGR babies, intrauterine growth retardation, we have found a lot more they are having premature adrenarche and polycystic ovarian syndrome later on. So multi-specialty involvement is there, and these are the evidences that came up. There are 4 study reports where VNTR class 1 alleles have been identified being causing this programming. A linear process as a result of programming of the adrenal, whereby hyperandrogenemia starting in utero. So we have now become more and more convinced that why should we treat a PCOS woman and not tell them just to take OCPs and sleep. So IUGR nowadays are being associated with premature adrenarche, early puberty, PCOS, and fertility problems. Coming to more evidences where DHEAS levels have been found to be higher in average and older low birth weight babies. They will be having more DHEAS in the later life, and this is causing disruption in the ovarian differentiation. And lot of evidences, you can go through it, but what is the new approach of treatment? So kisspeptin antagonists have been found out. If a prenatal exposure to this kisspeptin antagonist is given, it is found in a rat model that PCOS are not developing. So maybe the new approach of treatment will be kisspeptin antagonist, which may amend the disrupted HPO axis in a PCOS cases. Now last point, which should keep in mind the older woman, and should PCOS be renamed indicating metabolic and cardiovascular consequences? So starting from the ovaries to hyperandrogenism, hyperinsulinemia, fetal origin, coming lastly to a metabolic, and this controversy is showing that metabolic S syndrome is found in 2 times more in PCOS women, which is 43%. And lipid profile is almost in 70% of PCOS women are in the dyslipidemia range. This is a very interesting trial report. It came up from the Endocrine Society, where 270 women with PCOS were taken. Of them, 60 had their mother's PCOS, rest were not. And the conclusion was showing that PCOS mothers of women with PCOS had a higher incidence of coronary artery disease, and where they are going to have myocardial infarction much earlier than the women who are not PCOS of a PCOS mother. So this was very interesting. Trial report came up, and then only we started looking at the surrogate markers. So in my clinic, we are measuring this for the last 2 years, intima media thickness as a surrogate marker of the cardiovascular risk, and in all cases, believe me, they are high. Coronary artery calcification rate is also more. They do not know. And this is very interesting. What about the LDL-C? So you find that from the age of 20 years, when a control population having LDL-C normal, and maybe later on they are going high at the age of 55, PCOS girls are having LDL-C high from the very beginning. Almost 70% of the PCOS girls are having high LDL-C, and the increased chances of atherosclerosis from an earlier age. So this is a WISE study report, Women's Ischemic Syndrome Evaluation. So if somebody has got a heart attack, and the interval of having the second heart attack will be much less if she has PCOS. So our take-home message is, what is our responsibility goes not only to diagnose, but diagnose early and treat them properly. So when you are diagnosing anybody having PCOS, don't just say you have got PCOS, go and take the medicine. Tell her that you are the woman who at the perimenopausal age having increased chances of dysfunctional bleeding, endometrial hyperplasia, and certain chances of endometrial carcinoma. Please tell her you might develop type 2 diabetes, dyslipidemia, obesity, hypertension, and possibly cardiovascular disease. Also tell her you have got a sister, your mother, and blood-related women folk in your family are at a higher risk of cardiovascular disease. also not in our country but abroad, these are the women who have to pay more and are not covered with all diseases in Mediclaim, because they are going to have a lot more increased chances of cardiovascular problems. So from now onwards, don't think PCOS is an ovarian problem or only hyperinsulinemia, but in utero it is IUGR, peri-puberty it is exaggerated adrenarche, in the adulthood PCOS, and aging diabetes, cardiovascular disease, endometrial cancer. So please diagnose all women coming to us, whether she has got MS or not, that is metabolic syndrome, looking at 3 of these 5 markers, because 37% of the Indian women will have MS. Please, in a postmenopausal woman coming to it who is no longer menstruating, so you cannot diagnose by Rotterdam criteria. What should you do? Ask her up this: history of irregular menses, history of personal infertility or recurrent miscarriage. Look at the Hirsutism, which will be more after menopause, but also look at the SHBG level. Look at the central obesity, the waist circumference, very easy to measure with a tape, more than 88 centimeter, and look at the features of insulin resistance. If it is so, please send her to a physician to get treated. So in our clinic, we're doing a series of trial reports, which have already come up with the lipid profile, and that is in line with that report comes up internationally. We have done a genetic polymorphism study with Science College Rajabajar, and it's showing that vitamin D is playing a role exacerbating PCOS. We are having 3 consecutive studies over here. Carotid erythema thickness we're measuring after 40 years of age. We are measuring the brachial artery Doppler studies in PCOS women. And we are doing one survey on the knowledge, attitude, and behavior of the girls and women up to the age of 50 years regarding PCOS and prevention of CVD, because they do not know. When you discuss about it, it's a sort of a counseling. Not only you get the data, they also come to know that they should be conscious about their diet, their lifestyle management, and they are going to have increased chances of cardiovascular disease. Do not feel ashamed of telling her that. Do not feel that they will be alarmed. They should be alarmed. So these are the names. I request all of you to put forward name, whoever can do it, and if it is acceptable, then you become famous in your life. So thank you very much, and thank you for your patient hearing, sir.